rescue of 1,174 people from Wuhan, China, and the Diamond Princess cruise ship in Japan is a testament to the agility, proficiency, and dedication of our workforce, our interagency partnerships, and others to accomplish our core mission, advancing the interests of the American people. Following the SARS outbreak of 2004, the U.S. Government Accountability Office recommended that the department work with interagency partners and the private sector to develop capabilities to support the medical evacuation and transportation of U.S. citizens from areas impacted by the sudden outbreak of infectious disease. In the 2014 Ebola virus disease outbreak again served as a reminder that the department must have a standing crisis response aviation capability to protect U.S. employees and citizens when emergency situations arise. Such a prompt repatriation of U.S. citizens from quarantined conditions could not have been possible had it not been for the Bureau of Medical Services' existing aviation contract and solid corporate partners. The MMAS contract is the department's only standing response aviation support and critical care medical evacuation capability, and the U.S. government's only standing biocontainment transport capability. Upon receipt of the mission directives, we managed to configure and simultaneously choreograph the movement of 5 aircraft, including the coordination of all flight clearances, overflights, and other required logistics. Department of State personnel on board these aircraft were trained and equipped to manage these operations. The department successfully directed and executed a total of 7 flights over 4 missions, with evacuees transported to 5 different locations within the United States, equipped to safely receive, evaluate, and house persons exposed to the virus. This operation involved close coordination with our interagency partners, including the Federal Aviation Administration and the Departments of Defense, Health and Human Services, Homeland Security, and others. We also coordinated with international partners, including the governments of the People's Republic of China, Japan, the Republic of Korea, and Canada. I was the lead medical service officer overseeing these missions and led the 2nd and 3rd mission on the ground in Wuhan. Some 41 countries and territories have reported cases of COVID-19 infection, placing the health of our employees and U.S. citizens in these countries and territories at risk. In these unprecedented times, the department's medical professionals are committed to doing everything we can for the health and safety of our workforce and the U.S. citizens overseas. In summary, I'd like to thank each of you for your continued support as we keep pace with this international emergency. We know that your support to the department, the Bureau of Medical Services in particular, has made this all possible, and that your continued support will be critical in the months and years to come. Thank you.
Thank you, Dr. Walters. Director Redfield.
Well, thank you, Chairman Bear and Ranking Member Yo and the members of the committee for the opportunity to speak to you today. CDC, the Department of Health and Human Services, the State Department, and other U.S. government partners are fully committed to confront the serious global health threat presented by coronavirus disease 19. CDC's public health approach to COVID-19 is built on decades of infectious disease expertise in prior public health emergencies such as SARS, MERS, Ebola, and pandemic influenza. Our goal is to keep America safe and to slow the introduction of this new virus into the United States. Our response involves multi-layered, aggressive containment, and potential mitigation measures as needed. These proven effective public health interventions include early diagnosis, isolation, and contact tracing. These public health interventions also include targeted travel restrictions as well as the use of quarantine for individuals returning from transmission hot zones such as Hubei Province, China, and the Diamond Princess cruise ship docked in Japan. Internationally, CDC is working with the World Health Organization and ministries of health across the globe to continue to combat this outbreak. CDC has deployed over 600 staff to the response, including staff supporting Japan, South Korea, and our country office in China. This outbreak underscores our national leadership role on the global scale and the necessity of strengthening our global capacity to stop disease threats at their source before they spread. When this outbreak was first reported in December 2019, China reported 27 cases of pneumonia linked to a seafood market. Today, there's more than 78,000 cases and over 2,700 deaths. Over the past 2 months, we've seen confirmed cases reported in 46 international locations, including the United States, and several of these countries now are reporting sustained community spread. In the United States, 15 cases have been confirmed by our nation's public health and medical community based on clinical guidance provided them by CDC. On February 26, CDC confirmed an infection with the virus caused by COVID-19 in a person who reportedly did not have any relevant travel history or exposure to other COVID patients. It's possible this could be an instance of community spread of COVID, which would be the first time this has happened in the United States. 3 cases have been detected among the Americans repatriated from Wuhan, and another 43 cases were confirmed among the cruise ship passengers that were repatriated from Japan. We commend the efforts of the government of Japan to institute quarantine measures on board the ship, and we appreciate Japan's cooperation with the United States government to evaluate and care and evacuate American citizens. CDC works in partnership with the State Department to assist in this repatriation effort of American citizens, both from China and Japan. All of the individuals repatriated from Wuhan by the State Department charters have now been released from their mandatory quarantine. These individuals are not at risk of spreading the virus to others and should return to their normal lives. Passengers from the Diamond Princess are in the process of completing their quarantine at several locations across the United States. We are grateful to all the Americans who have and still are undergoing quarantine for their patience and their cooperation, as well as their willingness to ensure that they, their families, their communities, and our nation remain safe. We also want to thank the Department of Defense, the military personnel, their families on the installations where the evacuees have been quarantined for their hospitality and service to our nation. Efforts to direct flights from mainland China to 11 U.S. airports continue. CDC is working closely with Customs and Border Protection to screen arriving passengers from mainland China for illness and to identify people at high risk of exposure to this new virus and ensure that they are referred for the appropriate public health follow-up. To inform future travelers of the virus and where it's spreading, CDC continues to post travel advisories and alerts. Specifically, China and South Korea are now level 3 warnings that advise travelers against non-essential travel. Finally, CDC's current assessment into the United States is the risk of this infection remains low. However, we do anticipate new community cases. We have implemented a successful containment strategy, but we must be prepared to move to a blended containment mitigation approach. We also need to make sure we continue to strengthen our public health infrastructure, as alluded to by the chairman, and is ready for broader community spread. CDC and HHS will continue to keep members of Congress informed of new developments. We recognize that you are trusted leaders in your community, and communication with the public is essential during this emergency. Thank you, and I look forward to your questions.
Thank you, Director. I will now turn to my opening questions, and then I'll recognize the ranking member and our other members for 5 minutes for the purpose of questioning the witness. Director, in my opening statement, as well as you alluded to it in your opening statement of this potential first patient of community spread, and it is in my home county, Sacramento County, at and the patient's housed at the hospital that I used to attend in and have taught lots of medical students in. You know, in talking to my colleagues earlier today and getting a sense of you know, the timeline of this patient, one thing is a bit concerning. You know, I've taken care of patients like this who get transferred up, who are intubated, who you don't have a sense of what the respiratory diagnosis is. You know, cultures are coming back negative, et cetera. And in this case, it does seem like last Wednesday, the medical staff asked for a test of coronavirus and were told this patient didn't meet the criteria and this was not a coronavirus patient. As the patient worsened, it does sound like this past Sunday, there was an insistence and a strong push, and ultimately the patient did get tested. And we know the results that came back 72 hours later as a positive test. A question that I'd have, and maybe it's twofold. Number one, what current criteria are we using to determine who's going to get a test and who's not going to get a test? You know, when a doctor caring for this patient and they're looking at a patient, they request that it's a no-brainer. We ought to do that test based on the medical expertise of the folks that are trying to confirm a diagnosis. At a minimum, with this new case, we ought to rethink what those criteria are, and I'd be curious to hear what criteria we're using today and if the CDC is updating that criteria. And then the second component is, you know, our testing capabilities seem a bit too slow at this juncture, and I'd be curious to hear what we're doing to increase the rapidity and availability of tests if we are getting testing kits out to all 50 states as well as, you know, more broadly to you know, cities and others. And then, you know, it did take 72 hours from testing to get the results. And, you know, if we could get those testing facilities a little bit closer, I'd be curious to see how CDC is thinking about that. And I'm also told one of my sister institutions, UCSF, they've produced a more rapid test, need the ability to get some samples to confirm the specificity and sensitivity of that test. And there's some private sector companies that are also working on rapid diagnostic tools as well. So, Dr. Redfield.
Mr. Chairman, thank you for the questions. First, I think you know when this outbreak started, for better or worse, even in China, it was linked to whether you were exposed to the sea market, or food market. So obviously every confirmed case was from the market. And then when discussions I had with the Chinese CDC director, I suggested they go out and look at other people with flu-like illness, and of course then they reported that there were many cases that were not on the market. When the United States began this PUI, we had the epidemiological advantage of a link to Hubei initially, where most of the cases came from. Clearly, what's been demonstrated by the recent case is that's no longer operational. I will tell you that as soon as that case was recognized, we met and we revised our case definition for persons under investigation, and today that has been posted along with a new health advisory that the recommendation should be when a clinician or a public health individual suspects coronavirus, then we should be able to get a test for coronavirus. So that's the current guidance that went out today. And this is a fluid situation. And your second question is also critical. How do we expand the availability of testing? We think it was an accomplishment to, within a week, to develop a test so we could get eyes on this, and I think the CDC scientists were able to do that. But that was not to take away the broader responsibility for the private sector to come in to be able to provide broader testing for the non-public health community. We've had aggressive discussions about how to expand that, and we are continuing. We have shipped our kits, as you know, initially out to many, many jurisdictions. We had trouble with one of the controls. That has now been corrected, and there are now 40 jurisdictions that have the ability to do the test modified with the FDA approval. And in the next, today, tomorrow, we anticipate more kits from the private sector that have been contracted by CDC to get out. And hopefully, our real goal is that LabCorp and Mayo Clinic and others, but you get at the root of it, why is there a difference? And I used to run a diagnostic lab and develop tests. The other countries have the ability for someone like me to develop a laboratory test and to deploy it. In our country, we develop a laboratory test and we need to go through a regulatory process in order to get it deployed. And again, I'm not criticizing the regulatory process, I'm just saying that's the difference. And many labs in this country, many hospitals could stand up, as you mentioned, San Francisco and other, your own, Davis could stand up a test within several days, because we've published the sequences and the methods and exactly how to do this, and that's how that one company, IDT, is now ready to sell a test, which is really basically a copy of the CDC test. So I do think we have to look at that, because this is an example where we were slowed, in a sense, because of the way we want to assure accuracy of these diagnostic tests. And I know you all are wrestling with that, but we are having more kits out later today that are going to be sent to the states. The state of California, I talked to your Secretary of Health just today because they were down to 200 tests. We're sending more out there. There are 3 laboratories now, I'm told, in California that have the ability to do the tests themselves. But both of your points are very, very important. We take them very seriously. One of least we're not going to let happen again because we corrected it after the first case. And the other, we're working hard to get these tests out and hoping that the private sector comes in for the clinical use. CDC develops them for the public health use, and we need the private sector to come in for the clinical.
Director, I appreciate the change in the criteria and applaud that. I do think this is a unique situation where we need all hands on deck, and we do need to take a look at speeding up the regulatory process. We do need to allow the academics and those that have the ability to develop their own testing capabilities to quickly move through the process to make sure these are sensitive and specific and accurate diagnostic tests. And then if the private sector can augment our ability, especially now that there may be community spread, we've got to stop the bottleneck and we've got to get these tests out to all parts of the country. So we can take that up here, but I do, looking at the administration, whatever we can do to speed up that regulatory process to make testing readily available to the practitioners that are out there. Yeah, with that, let me recognize the ranking member.
No, I appreciate it, and I appreciate y'all's testimony. And I think what you were just bringing up is a lot of the questions I had. I assume it's a PCR test or an ELISA test. Okay. The variation in those, you guys created that, and I think along that lines there should be provisional approvals quickly. And that's thing, if you guys are in a bottleneck where you can't get that, let us know so we can help relieve that, and then do the testing and verification down the road. But you have to have a place to start. And then when we get to the point where we have private manufacturing of these, we just need to make sure that we're all on the same page, it's the same test, so we don't have a variation in sensitivity or specificity, and that we need to make sure that the other countries are doing the same. My concern is, with so much of the APIs being created in China, about 85% plus is what I've heard, I look at it from a national security standpoint, or a national health standpoint. Not just our country, but other countries. If somebody needs Advil and you've got a population of 1.3 billion people, are they going to service their customers first before over here? And I think this is a wake-up call for American manufacturers in our pharmaceutical countries not to be dependent on a country. What are your thoughts about that? Whoever wants to tackle that. Mr. Fritz, you're the one.
Thank you, Ranking Member Yoho. There's clearly going to be all sorts of economic impacts as the outbreak continues to develop. We are paying very, very close attention to not just the general macroeconomic impacts that are going to occur with regard to the United States economy and other economies around the world, but also to the impacts on supply chains, and particularly, as you mentioned, supply chains that are important to our ability to react to future instances, future outbreaks. I don't have anything that I can share with you right now, Ranking Member, in terms of what those responses will look like, but it is something that we're looking at very carefully. And we have people across the interagency process who are actively considering ways we can make sure that we are able to make sure that we do have access to the necessary supply chains.
All right. Let me ask about the cooperation. Do you guys feel that the cooperation is adequate with the Chinese government as far as transparency, just working side by side, or do you feel like it's, here's the information we'll give you, and kind of guarded?
Sir, why don't I take a first shot at that on, certainly with regards to the evacuation of our personnel and American citizens, very diplomatically and logistically challenging. I would have to say that we were able to achieve a very high level of coordination with the relevant Chinese authorities to make the 5 flights that we got into and out of Wuhan happen. They weren't easy, but we did, in fact, we were able to rely on our Chinese counterparts working with us to make sure that those succeeded.
Do you feel like they're treating all the countries that way? Because we heard the reports that they weren't letting the Taiwanese out.
I
Or
wouldn't
that
be
they
able to
sent some
characterize
sick-
whether they've been treating everyone as well as they've been treating us. I do know that they have worked well with a number of other partners, but I've heard the similar reports about our friends from Taiwan being treated differently with regard to their evacuation plans. I would say in general, however, I think the PRC authorities have generally made good faith efforts to help evacuate folks from Wuhan of other nationalities.
Does anybody have reports about this being in North Korea, which I would assume it is? I mean, do we have any definitive proof?
We don't have any confirmed reports. Yeah.
Okay. Let's see. I think with that, Mr. Chairman, I'm going to yield back, and I appreciate everybody here. I look forward to the questions, and I'm going to gather some more information. So thank you all, and I know working together as you are, we will be prepared for this in the United States, and hopefully we can be the ones that help the other countries the most. Thank you.
Great. Gentleman from Michigan, Mr. Levin's recognized to question the witness for 5 minutes.
Thank you, Mr. Chairman. On Tuesday, Nancy Masonier, the director of the National Center for Immunization and Respiratory Diseases at the CDC, said this of coronavirus. Ultimately, we expect we will see community spread in the United States. It's not a question of if this will happen, but when this will happen, and how many people in this country will have severe illnesses. But National Economic Council Director Larry Kudlow then said, "We have contained this. I won't say it's airtight, but it's pretty close to airtight," end quote. And also, this is all on Tuesday, President Trump said of the coronavirus in the United States, quote, that it's under control and a, quote, problem that's going to go away. So that was all on the same day. Americans are scared of this situation, and they want to know what's being done to keep them safe. And hearing mixed messages like this within the span of hours isn't reassuring. Dr. Redfield, how can the virus be both a problem that's going away and also not a question of if, but when? What should we be telling our constituents about what to expect?
Thank you very much. I think it's a very, very important question. Right now at this stage, and I've said this and I continue to say it, the risk to the American public is low. We have an aggressive containment strategy that really has worked up to this time, 15 cases in the United States. Until the case that we just had in Sacramento, we hadn't had a new case in 2 weeks. We do believe we're going to continue to see new cases, and we do believe now there may be the initial cluster or occurrence of a community acquisition. Some countries, this has moved very quickly, like we saw in Korea now, where we had more cases in Korea in the last 24 hours than we had in all China.
Right.
We see it in Italy, it's moving fast. Iran, it's moving fast. But other countries have really used a containment and a blended mitigation strategy like Singapore and Hong Kong, and they've really limited the spread after the initial introduction from China. We're of the point of view that we're still in an aggressive containment mode, which is dependent on early case recognition, isolation, and contact tracing, that now is going to be looking to identify these community introductions and practice public health to minimize them. But at the same time, we've done this to give us time, and I think what Dr. Messonnier was trying to say, I think it was maybe could have been done much more articulately from what the American public heard, was she was trying to say it's also a good time for us to prepare if we have to go to more mitigation. We're still committed aggressively to get aggressive containment. And I think I want the American public to know at this point that the risk is low. I want them to know that we are going to start identifying more cases like we did the other day. I'm going to ask them to obviously accelerate their own view of the standard things that we do for flu, hand washing, cough in your sleeve, don't go to work or school if you're sick. And we have launched a larger, for our next level of our multi-layered public health response, is to now institute broad surveillance. and we've initiated it. We're planning over the, hopefully the next 4 or 8 weeks, obviously linked to the supplemental, to actually make our surveillance system for corona the same as flu, nationwide. So we can be, very quickly picking up when there is an introduction in a community, go in and try to stop it. So I think that's our position at this point.
Good. Well, let me quickly ask you one other question, my limited time. I want to ask you to speak about the danger of xenophobia in a situation like this. CNN reported last month on disturbing example from the SARS outbreak when, and quoting them, people of Asian descent were treated like pariahs in the West. There were reports of white people covering their faces in the presence of Asian coworkers and real estate agents who were told not to serve Asian clients, end quote. We saw similar incidents during the H1N1 swine flu outbreak in 2009 and during the 2014 Ebola outbreak. And sadly, I've heard reports of incidents like this around coronavirus. So I'd like you to talk about why it's so important to avoid stereotyping people as carriers of the coronavirus and how incidents like these can be avoided and how they're dangerous really for public health.
I couldn't agree with you more. For those who've heard me talk before, I've always said that stigma is the enemy of public health in all its forms, whether it's in dealing with HIV, whether it's dealing with drug use disorder, whether it's dealing with obesity, whether it's dealing with a response to the coronavirus at this time. Stigma has no role, no place in public health. It's counterproductive.
So I think we're going to have to proactively get that message out to the American people so that we don't harm our own public health with stereotypes folks might have. Don't you agree?
Yeah, I will continue to echo it, and I think you make an important point because we have seen those reports, and I think, again, we need to re-echo that stigma has no role in public health.
Thank you, and thank you, Mr. Chairman. I yield back.
Thank you. The gentleman from Florida, Mr. Mass, is recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Redfield, I want to start with you, and you spoke specifically about early diagnosis being part of the positive that's going on here. Can you discuss with me what are early symptoms which lead to early diagnosis?
I think the first thing I want to say is there's a lot we don't know, and we're learning more each day. That's what concerns those of us that are confronting this. If it was flu, we understand flu. But there's a lot we don't know. But what we have learned in the last 8 weeks is that this virus can actually cause asymptomatic infection. No symptoms. Now that's complicated when you're dealing with a public health threat, if you can have it. And on the Princess ship, over 50% of the individuals that were diagnosed in the process in Japan lack symptoms. Now, there may be an ascertainment issue because they thought if they had symptoms, they'd be treated different. But clearly, there's a significant percentage of people that lack symptoms. And there's clear evidence now that we've learned those individuals can actually transmit the virus. So as the chairman knows, from a public health point of view, that makes this more complicated. The other side of it, its symptoms can be as negligible as a scratchy throat, a dry cough. And you can see that's why initially we had PUI definitions that were pretty narrow, because if all of a sudden everybody with a scratchy throat or a dry cough during flu season came, then we had some perplexities. At the severe end, it can cause really a very significant pneumonia, respiratory compromise, requiring critical care. And overall, it does look like 5% of individuals in the China situation are critical, 15 need critical care. Other countries are starting to show similar. But on the other spectrum, there can be this asymptomatic illness. So we're still learning. It's complicated. Obviously, in the individual case that we talked about here, where severe pneumonia in an otherwise healthy individual, in light of what we now know, that can prompt the medical community to consider the coronavirus in the differential diagnosis. But a lot of individuals may just present with a sore throat and a dry cough.
Let me go to the other side of the table. 80+ thousand cases diagnosed, and the number that I've read is 33,000 recovered in mainland China, recovered from having the diagnosis. Can you say what has been a chief factor that has led to those that have recovered through it? Is that something that we know?
I think there's probably two major factors. One, or maybe three. One is age, and one is comorbidities. So individuals that happen to have diabetes or hypertension or chronic obstructive lung disease and happen to be elderly, these individuals have a much higher mortality. But the other issue that needs to be stressed is the effectiveness of the healthcare system. So in Wuhan, the mortality right now is somewhere over 4%. Their health system is beyond strained. Before this outbreak, they had 132, I think, isolation beds for infectious disease. Today, they have over 20,000. Now, you can go from 132 beds to 20,000. You can build the structures. But as the chairman knows, where are the doctors? Where are the nurses? Where are the ventilators? Where is the trained healthcare professional? So we see a mortality, and we believe it's the integrity of the health system that is a major factor, because if you just go to the rest of China, the mortality is probably about 0.5%. Okay, so I think the major factors I would say with comorbidities, age, and the resilience of the health system that you happen to be in when you get sick. If you don't have access to oxygen, the mortality is going to be a lot higher. This is why we're worried about Pakistan, Afghanistan, Bahrain, North Africa, all the countries that have come on board recently. Many of them don't have health systems that are going to be able to sustain life in the presence of pulmonary compromise.
This is something you have a lot more faith in our health system, obviously, than Wuhan or pick any of the other countries that you just listed off.
Yeah, I think we're in a strong position. We have an effective healthcare system. I think, at this stage, if we can continue to do what we're trying, early identification, find these community cases, get our arms around them, I think we can continue to respond. Obviously, if the numbers get to the point that we can't control, then that's a totally different part of game, totally different issue. But right now,
I'll pause you there because my time is about to end. Just to say, I think you mentioned something that is important to realize about this, that our health system has a different starting point than that health system of Wuhan and many other places. Certainly doesn't make us impervious to this, but it's a better starting place to be at. Thank you for your comments.
Thank you, Mr. Mass. The gentlelady from Pennsylvania, Ms. Houlihan's recognized for 5 minutes to question the witness.
Thank you. I'm actually going to start. I know that it's my obligation in some ways to ask complicated questions about policy, but Dr. Redfield, I'd actually like to start and lead off of Mr. Levin's conversation for the human beings who are at home, my kids, my family members, my community, and ask the doctor you are the 18th director of the Center for Disease Control and Prevention and administrator of the Agency for Toxic Substances and Disease Registry. And in your capacity, could you help me to answer a few questions that I frequently get asked? The first one, they can be any answer. I don't know the answers. I'm just asking on behalf of my community. Should people be afraid? Thank you. Could you turn on your microphone?
No.
Should people engage in regular hand washing and coughing into their sleeves?
absolutely.
Should people be stocking up on cleaning supplies?
No.
Should people be stocking up on prescription medications that they have?
Not at this time.
Should people be stocking up on food supply?
Not at this time.
Should you wear a mask if you're healthy?
No.
And is there a website, and you can answer this later if you don't know it by heart, where people can go to access good information about these questions?
Absolutely. The CDC, cdc.gov, we have all of the information on that website, and a sub thing can take you to coronavirus and where we are and any preparedness and all our recommendations.
And sir, is there anything else that I should have asked you that's a regular, everyday person kind of question?
The one comment I would make, because I do see people feeling a need to go buy masks. And I would ask them, and some people scoff at me when I say this, we need to make sure those N95 masks are available for the doctors and nurses that are going to be taking care of individuals that have this illness. And it really does displease me to find people going out. There's no role for these masks in the community. These masks need to be prioritized for healthcare professionals that, as part of their job, are taking care of individuals and/or individuals who have this virus and are in home isolation or home quarantine for those family members. So I'd like to have the, prioritize the uses that we recommend and get people to realize that that's where these masks need to be reserved for.
Thank you. I appreciate that. And with the last couple minutes of my questioning, I think this is either for Mr. Fritz or for Dr. Redfield based on how people have answered questions. I'm going to follow up on the line of questioning that has to do with prescription and pharmaceutical supply chains and the integrity of the supply chain. Is there a place, a way that we have historically been tracking various supply chains? In my old business, we would make sure that we had at least 2 or 3 suppliers of the same material just in case. Is there something that we have, a database or other system that tracks those kinds of suppliers and where they are geographically?
Thank you, Congresswoman, for the question. As I mentioned, there is a very intense interagency process underway. I think HHS, in particular, the Food and Drug Administration and other relevant agencies are all looking very carefully at this exact question and making sure that the answer to that question going forward is that we do have access to whatever we need to sustain ourselves in the current outbreak and to make sure that we're ready for future ones.
So I understand that the FDA largely is, sort of lead on this, but is there a role that the State Department can play on this? Is there something that we at this body can do to be helpful in that?
What the State Department is doing is we're looking very closely at the impact of the outbreak on our global supply chains. And of course, we're working with some of our other foreign affairs and trade-related agencies to map that out. And then we're, again, together with HHS and others, looking at how that impacts our ability to access what we need in time of crisis here in the country.
Yeah, and I'm just looking for this to be sort of a sad lessons learned. How can we take this experience and make sure that doesn't happen to us again? How can we make sure we know where our suppliers are and how to make sure that we are safe from this kind of exposure again?
Yes, ma'am. I mean, I think this crisis is teaching us that we need to pay very, very close attention to this in the era of globalized supply chains. And we are bound and determined to make sure that whatever lessons are learned from this are applied going forward.
Thank you. And with my last half a minute of conversation, I just wanted to kind of take off on something that we were happy that our healthcare system was better than Wuhan. That's awesome. But can you comment a little bit more about how we need to work with other nations to make sure all of our healthcare systems are working together in tandem on this?
Thank you for that question, ma'am. I would like to point out that U.S. foreign assistance over a number of years now has focused in large part on helping countries around the world build public health systems that are able to be resilient in the face of these sorts of crises. Of course, that is being put to the test in many instances. I think what we can say is things probably would be much worse if it had not been for our efforts over a number of years to share best practices and actually make resources available to build capacity around the world in this aspect. And of course, we have announced up to $100 million of assistance for partners around the world to respond to the COVID-19 crisis.
Thank you. I've run out of time. I yield back.
Thank you, Ms. Sulan. The gentleman from Ohio, Mr. Shabbat's recognized to question the witness for 5 minutes.
Thank you very much, Mr. Chairman. Mr. Fritz, I'll direct my question at you if I can. I was one of the original founding co-chairs of the Congressional Taiwan Caucus, and I'm now one of the co-chairs of that caucus. And as you know, and as we all know, the PRC, China, considers Taiwan a breakaway province. Taiwan, for all intents and purposes, conducts itself as an independent nation, not necessarily recognized by the world as such, but it is, and the people there are free. They ought to be a model to other countries around the globe. They've been bullied by the PRC for many years now. But my question is this: they have sought to be recognized as on observer status, basically, at the WHO for many years. In my view, they ought to be essentially a fully recognized participant in the WHO. It's kind of a gap in our world health system in not recognizing them, not letting them fully participate. But at this point, China has still blocked them from so participating. With something as serious as the coronavirus, and obviously its origins in the PRC, in China, and Taiwan being right next door, and Taiwan having some of the top medical institutions and doctors, medical personnel in the world there,
you know, it seems to make no sense that China continues in this effort. Taiwan could be helpful, even more helpful to China. So what gap does this create in the world's response to this very serious medical and the situation we have with the coronavirus? What's the problem with what China is doing relative to Taiwan?
Thank you very much for the question, Congressman. As you said, Taiwan is a robust democracy. It's a model in that respect. It's a reliable partner on public health and a number of other concerns that we share. And it's a force for good in the world. I couldn't agree more. And I think this COVID-19 outbreak only further underlines the unacceptability of Taiwan being excluded from the World Health Organization and the World Health Assembly because the People's Republic of China blocks every attempt for it to do so. As you mentioned, not only has the COVID-19 outbreak affected Taiwan, they have 30-some cases there. And to the extent that they are unable to get timely information from the WHO, that impacts public health on Taiwan. On the other hand, as you pointed out, Taiwan has a lot of expertise and they have some experience, and in fact, they have their own epidemiological track record now dealing with COVID-19, and to the extent that that is not being shared in a complete and timely fashion with other WHO members, clearly that doesn't do anything for the public health of the rest of the international community, which is, of course, why the United States has and continues to push very hard for Taiwan to have meaningful participation in the WHO and to be granted observer status at the World Health Assembly. China, it's worth pointing out that the People's Republic of China was okay with Taiwan being an observer back when a different party was in power in Taiwan. So through 2016, Taiwan did have observer status at the WHO. It's only when the Democratic, the DPP party came into power in 2016 that China began blocking across the board Taiwan participation. And we continue to push back very, very hard against that with as many of our like-minded partners as possible. And I think our argument is only bolstered now by the COVID-19 outbreak. And I would point out that this push by the USG is fully consistent with our U.S. One China policy and, of course, with the Taiwan Relations Act, which governs unofficial relations between the United States and Taiwan.
Thank you very much. My time's almost expired, so let me just reiterate what you said. I agree with all the points that you made. Thank you for that, and I want to thank the administration for continuing to be a friend to Taiwan, and we would encourage it to continue to do so, even step that up. And it's a shame that the PRC, China, allows its intransigence with respect to Taiwan to put not only the people of Taiwan and its own people, but the rest of the world more at risk than we ought to be. So they ought to do the right thing here and allow Taiwan not just to be observer status, but to be a full member of the World Health Organization, the WHO. Thank you very much.
Thank you, Mr. Chabot. The gentleman from Rhode Island, Mr. Cicilline, is recognized to question the witness for 5 minutes.
Thank you. And Mr. Chairman, I want to thank you for the courtesy in allowing me to participate in this hearing. And thank you to our witnesses for their testimony. Dr. Redfield, I want to ask you kind of to follow up a little bit on Ms. Houlihan's question about the supply chain, because as you have described this potential pandemic becoming really a global challenge, I guess it already is by most estimates, what are we doing to assure that there's a sufficient supply of, medical supplies? You mentioned oxygen. I mean, do we have a coordinating body that's figuring out if this pandemic proceeds in a serious way in this country, that we'll have access to the resources we need, both for the kind of containment you've spoken about and treatment? And is there someone doing that sort of planning?
Yeah, that's not really within what I do at CDC, but I will tell you that the Assistant Secretary for Preparedness and Response, ASPR, has done extensive work, and it was mentioned by Mr. Friss. There's an interagency group that's really going through this in quite detail with the FDA and ASPR in terms of many of the medical issues. But there's a broader intergovernment group doing it in the broader issues. And so I can tell you that's ongoing, and We could obviously get to you who's the leadership on it, but I know ASPR and FDA have done it on the medical side, and there is a broader intergovernmental working group to really get down to all of these issues.
Great. And you also made reference to the Chinese CDC, or counterpart. Can you speak a little bit about the relationship between the CDC in the U.S. and the Chinese, particularly as it relates, I'm particularly interested in this healthcare worker transmission. 2 weeks ago, China reported 1,700 healthcare workers had been infected by coronavirus, and just wondering what we're learning about that transmission and whether or not that's informing protocols here in this country to protect our healthcare workers.
Yes, thank you. The CDC has had now over a 30-year working relationship with China CDC. There's a reason they call it China CDC. And I actually have a U.S. CDC component that's affiliated with the embassy, but is attached to the China CDC. The head of CDC, China, and I have been in regular discussions since the very beginning when this happened on New Year's Eve, and had very open scientific discussions about what he knew at the time, what he was learning, so we could use that information. And that continues bidirectionally, as I say. From at the beginning, there was not a thought that there was human-to-human transmission and nosocomial transmission. They saw that, in the first week, they didn't see any in the second week. But remember, they were using, a definition of whether people were very severely ill. They weren't recognizing that this could be mildly symptomatic. Since then, there's obviously been extensive hospital-based transmission. And one series that was published in one of our journals in JAMA recently showed that up to 40% of the cases got infected either because they were healthcare workers or because they went into a hospital where they were infected after they got there. So healthcare transmission is really a high risk, particularly in areas that really aren't vigilant in the importance of infection control. We're happy to say to date, we haven't had a healthcare worker. Obviously, the new case, as was mentioned by the chairman, raises concern because people were intubated and not necessarily in precaution, so we're aggressively evaluating that healthcare setting.
And Dr. Redfield, could you just give us a quick update on the vaccine development status and whether or not additional resources are necessary, what the timetable looks like for that? I think lots of people are interested in that.
Sure. Well, the NIH, Dr. Fauci, has the lead on this, but I can tell you what he's told us and others is that they do have a candidate product that they are planning to move into a phase 1 trial, hopefully in the next 6 weeks, which will evaluate immunogenicity and safety, assuming that candidate, and they've partnered already with a private sector company, and assuming that goes well, then they would move into an expanded phase 2 trial. But in reality, if everything goes really well and they get the strategic partners that they need, he's saying he looks at a year to 18 months before we could have it. We do believe scientifically that this is a virus that should be able to have a successful vaccine based on the coronavirus, as opposed to if we were trying to do this, say, for HIV. We would say, well, we don't know because we're not sure how that's going to work or not. But for this virus, there's a lot of scientific reason to think that it will be successful. And the NIH is really moving forward very aggressively to try to make that happen.
Thank you very much, Dr. Thank you, Mr. Chairman. I yield back.
The gentlelady from Virginia, Ms. Spanberger, is recognized for 5 minutes.
Thank you very much. Thank you to the witnesses for being here. And as you might imagine, I am very concerned about this, the issue of this virus, and constituents across Central Virginia, the district I represent, are deeply concerned. So I want to start by saying thank you, Dr. Redfield, for what you said to my colleague, Representative Houlihan, which is that they shouldn't be afraid. I think that's incredibly important. I appreciate you being here today to talk about this important issue, but also to mention that, because so much of how we are handling this this disease, this outbreak, will also be determined by how we're communicating and what the temperament and feeling on the ground is. I wanted to speak very briefly about some local preparedness. And Dr. Redfield, I'll start with you. The coronavirus is expected to put additional strain on our healthcare system, and you've noted that our healthcare providers are already at near max capacity due to a bad flu season. How is the federal government ensuring that medical providers across the country have what they need and the resources that they need, and what else could we be doing?
A very important question, and I want to say that my partnership agency in the Health and Human Services, ASPR, has been working and continues to work to see that hospitals begin to get prepared. That's one of their essential missions to the Assistant Secretary for Response and Preparedness, ASPR. And so they are going through that in great detail. They've had dialogues with different hospital corporations, just hospital leaders, to begin to see that. Because you do say that this, for us, there's not a lot of flex in our health system right now. I mean, most hospitals right now, because of influenza, if you're looking at them, they may be at 95, 96, 97% capacity. This is why I stress that our current public health response, that multi-layered response, is containment, 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 to try to buy us time for the fruits of labors by NIH and Dr. Fauci and the private sector. So hopefully in the not too distant future, in a year and a half, 2 years, we'll have a vaccine. But I can tell you ASPR is very aggressively working and evaluating this, and the term they use is resilience, to try to make sure they can build resilience into the system.
And following up on that notion of containment, in order to contain, we need to identify it. And in your written testimony, you noted the importance of using illness surveillance systems. Can you tell us a bit more about how we are applying existing systems to this virus, and are U.S. public health agencies developing new surveillance, illness surveillance systems specific to coronavirus?
Yeah, this is really important. This is really one of the most important components from CDC's perspective in the recently requested supplemental. We have an excellent surveillance system in this nation for flu. We have multiple surveillance systems, as you just mentioned. We have the illness, we have multiple. And rather than recreate the wheel, what we have proposed, and we've actually begun this to at least initiate it, is we're really adapting our entire respiratory disease surveillance systems and now interfacing coronavirus 19. And, I'm very hopeful in the next 8, 12 weeks, we will be in a position that we will have your flu surveillance system, if you follow that, and you're going to have your national coronavirus system. I'm more interested in this, as I'm hoping is the canary in the minefield, in the mine, that I can see when and if we're getting community. I don't have to wait till an individual gets hospitalized and is on a ventilator. I have to be honest with you, we don't know what we're going to find when we start this, but we're very anxious to get this broad coronavirus surveillance system using all the systems that we have right now for respiratory disease and get that operational as soon as possible.
And to be able to see the trends that we may be seeing that, in fact, demonstrate that we're looking at potentially an outbreak in a locality or in a state.
Absolutely, and then be able to put the full power of the public health approach of case recognition, isolation, contact tracing to try to make sure that cluster is contained.
And do you have the financial resources and the employee capacity for this surveillance system and what you need into the future?
Well, I will say that's one of our major components of the supplemental that was put forward, was to be able for us to roll this out nationally.
Great. Thank you so much to the other witnesses. I know I concentrated my question on Dr. Redfield, but I do appreciate your time and your presence here today. Thank you. I yield back.
Thank you, Ms. Spanberger. The gentleman from California, Mr. Liu, is recognized to question the witness for 5 minutes.
Thank you, Chairman Behr, for calling this important hearing. Thank you, Dr. Redfield, for your public service, including your service to the U.S. military. The Washington Post published an article. Headline is, "A Faulty CDC Coronavirus Test Delays Monitoring of Diseases Spread." So my first question to you is, does the CDC's test for coronavirus work?
Yes.
Okay, what is the error rate on that test?
So we created a test really very rapidly based on the sequence of the virus, within really a week of the sequence being published. And it's a PCR-based test. And the way it was designed at CDC was it actually measures 3 different, if you will, components.
I just need to know the error rate,
Well,
if you know it.
yeah, the problem was when the test was sent to the states, one of the components had a contaminant in it. That's what had to be corrected. The test at CDC works fine. When it was given to a manufacturer to scale up for the states,
Has the CDC fixed it?
it has been corrected, and there are tests that are being shipped out as we speak.
Okay, so in fact, the first test didn't work.
First test works because it was developed at CDC and it works fine. We test everyone in the country. When the manufacturer scaled to send to the states, when the states got it, it could tell positives, it could tell negatives, but because of one of the contaminants in the control, there was another group that was, we don't know if it's positive or negative. It was inconclusive. And at that time, the FDA requested that we not use that test and have people send it to CDC, where the initial lots that we made were quite functional and there was no contaminant, and that's the test we continue to use today. There are now over...
All right, so I just need so the current test works.
Current test works.
Okay, great. So it's been reported now that 48 countries have coronavirus cases. In Italy, it's skyrocketed now to 650 cases. South Korea has now 1,700 cases. As you yourself stated, there are more new cases in South Korea than in China. Why is it that we're only testing people who have traveled to China? That seems to make not a lot of sense to me.
Well, when this outbreak originally occurred...
I'm talking about right now, not when it occurred. Right now, why aren't we testing
Well,
people who have traveled to South Korea, traveled to Italy, traveled to the 11 European countries where there are now coronavirus cases?
We're continuing the travel restrictions that were initiated...
No, I'm just talking about testing people. Why don't you expand the test? Because there's a person in Northern California that doctors recommended get the test. And CDC said no, because the person had to travel to China. That's just really stupid, because we know this has expanded way beyond China. 48 countries, every continent except Antarctica has these cases. We really should be testing people, not just those that have traveled to China. Can you commit to expanding the test to beyond those that have just traveled to China if they have the symptoms that look like they have coronavirus?
Congressman, I mentioned earlier, I think before you were here, just so you know, we initially had a geographic restriction. We have changed that. We've posted there's a no geographic restriction, that if a clinician or a health department official considers coronavirus in the differential diagnosis, that now meets our criteria.
When did you make that change?
We made that, well, yesterday we did it and we posted it today.
Thank you for making that change. Yep. Okay. So in terms of transmission, because earlier you said people shouldn't be afraid. My understanding, based on the articles, Reuters reported that coronavirus contagion rate makes it hard to control. And there are these 2 scientific studies that show essentially each person infected with coronavirus is passing the disease on to between 2 and 3 other people on average at current transmission rates. And then if you've got this long incubation period, potentially 14 days or more, you could have an exponential explosion of cases rather quickly, such as in Italy. Isn't that correct?
I think we've seen that obviously in Italy, Korea, and Iran, and yet.
So this person in Northern California who didn't travel to China, where we don't know where he got the coronavirus, he could have passed on to 2 more people, who passed it on to 2 more people, who passed it on to 2 more people. So there could be a whole cluster of cases. But until as of yesterday, we don't know, because we weren't testing anyone who didn't travel to China. Am I understanding this correctly?
The current public health evaluation of the case in the chairman's district is being led by the state public health system of California, and we're supporting it. We have a large number of contacts that have been evaluated, that are being isolated, that are being tested to really look at the fullest extent of the potential transmission around that case.
Thank you. I'm going to conclude by saying Donald Trump has attempted to minimize the coronavirus outbreak. There's an article in the Daily Beast titled Coronavirus May Explode in the U.S. Overnight, just like in Italy. I request that when the data and science contradicts what Donald Trump says, that you follow the data and the science. I yield back.
Yeah, I can just say that I commit that CDC is science-based, data-driven service organization, and that's one of the prides that I have to be the director now, to be in a science-based, data-driven, but most importantly, service organization.
Thank you.
Let me recognize the gentleman from California, Mr. Sherman.
Thank you. China failed to, well, actually hid this disease at the beginning. China continues to they try to exclude Taiwan from the WHO. There are a number of things China could be doing. We need Chinese cooperation to start clinical trials. Dr. Redfield, are we getting it?
There is a drug called remdesivir that's now in clinical trials in China and Japan, and it's been extended, there's actually into the United States to the repatriated individuals.
There's similarities, vague similarities to the flu. This flu is often seasonal. Is this, our president has said, oh, it's going to be gone by April. How confident are we that transmission will be substantially less when the winter is over?
It's unknown.
There are various treatments that are used for flu, such as Theraflu. Is there any reason to think that there's some chance that that would be helpful in reducing the effect of the disease?
Not for the coronavirus 19.
And likewise, the SARS vaccine, would that provide any protection?
It's unlikely that the cross-reactive, but the methods that they were used to develop that vaccine is the reason that Dr. Fauci's been able to accelerate the vaccine he's developing.
Good. And what's the earliest we could have a vaccine?
Well, Dr. Fauci has said one year to 18 months if everything goes well.
Gotcha. Let's see. How well are we cooperating with China today? Are they providing the information we need, and are our people on the ground? Mr. Fritz.
Thank you, Congressman. I pointed out a bit earlier that we did get we got good faith cooperation from Chinese officials as we worked to send in and get out our 5 plane loads of evacuees.
Well, I'm not talking about, yeah, but
so,
we have people on the ground at the epicenter of this epidemic getting information that's helping Dr. Redfield do his job.
I'll defer to my CDC
Dr.
colleague on the
Yes.
actual.
Are you getting what you need from China?
I have regular discussions with my counterpart, George Shao, as the head of CDC. We do have a CDC, a CDC that's embedded into the China CDC, so we are having daily interactions. I have a team of respiratory experts that are there, working there. At a scientific level, we're having good dialogue.
Congressman, if I could, I would point out that Secretary Pompeo and others have also, of course, made it clear that China's allergy to freedom of speech, freedom of expression, et cetera,
Well, yes,
have been obviously had a very negative impact on
The
the
initial
ability of Beijing
response
to-
of local officials was to try to keep it under wraps, and the failure to be a free society. That's why this thing got going, and we're now in a position that perhaps could have been avoided if China had a different policy toward free expression versus hide things and hope that you can keep them under wraps. Let's see. Why does the administration request for additional funding rely overwhelmingly on transferring funds from other disease-fighting accounts? Dr. Redfield, do we need to spend any money on Ebola? Can we just grab that money? No problem, though?
Obviously, we have an ongoing Ebola outbreak right now in the Congo. I really can't.
Do you think it's wise then to take all the money that we had appropriated for Ebola and not spend any money on Ebola?
I really can't comment on the budgetary decisions that were made.
Are you doing useful work that will save lives or may save lives with regard to Ebola? Are you, if we leave the money in the budget, will you spend it effectively in ways that help save lives?
We currently have an ongoing Ebola outbreak in the eastern DRC where we have a substantial number of CDC people deployed. And we are if you will, and I say this and knock on wood, we're finally close to winning, okay? We're down to, really, in the last week, we didn't have a single case. So we now project, based on our models, that we might actually end this outbreak by the end of June. But obviously, when instability happens again, we could be right back where we were 2 months ago. So,
And if this Ebola outbreak expands in the Eastern Congo, it could be a threat to the United States, just as a Chinese epicentered problem has been a threat to the United States and even to California.
well, we've been fortunate with Ebola in that there's very little movement from the Ebola Eastern Congo, where this outbreak is, and the United States. But we obviously have had to invest significantly in what we call exit screening from the Congo as we've dealt this. As you know, we've been in this outbreak now. We're almost about to start the third year.
But if we don't fight Ebola in Africa, does that mean Americans are safe and everything's fine, and you're assuring me that we can just not worry about Ebola and we're not going to have a problem this year or next year?
I think one of the most important things our nation can do is build a robust global health security capacity, all right, so that we can detect, prevent, and respond to these outbreaks at their source. And this is exactly what we're doing with Ebola. The more that we can expand that capacity, and I believe strongly it's a core mission of CDC, we're the tip of the spear to identify these infectious disease threats. And obviously, we appreciate your continued support in that regard, because what we're seeing with the coronavirus is just another example of why it's so important that we have global leadership in the ability to detect, prevent, and respond to these outbreaks.
I would just comment that the outbreak of this coronavirus demonstrates the importance of your work and the absolute folly of pulling the plug on some of your work because of an unwillingness to fund the additional work that we need to do for the coronavirus. With that, I'll yield back.
Thank you. I'm going to use the chairman's prerogative to ask a couple questions because I feel bad, Mr. Brownlee, Dr. Walters. I appreciate your coming down and seeing. I don't know if I'm doing a favor asking you questions or if the goal as witnesses is to slide out of here with no questions. But I appreciate your coming down. Mr. Brownlee. I hear your concerns, and we'll continue an ongoing conversation about flexibility and consular functions. I've been honest in my concerns with the administration in announcing travel restrictions for individuals coming from China. I understand the rationale and reasoning behind it, but also have some concerns about whether it's going to do what we hope it does with regards to containment. Mr. Brownlee, going forward, though, are we considering similar measures against other nations? And if we are, under what specific circumstances? And then the last question would be, as the CDC and the State Department issue travel advisories for countries who have been impacted by coronavirus, what specific objective criteria are we using to make these determinations? Maybe, Dr. Redfield, that's a question for you. Mr. Brown.
Thank you very much for your question, Chairman. With regard to further 212F possible proclamations, this remains the prerogative of the White House. They are gathering information from all available sources as to whether further restrictions might be necessary to help contain the virus. As Dr. Redfield has noted now several times, we are still in the containment phase. Whether CDC and other public health authorities will recommend that is beyond my scope. With regard to travel advisories, this too is something we revisit constantly in the Bureau of Consular Affairs. We are looking at a variety of different issues with regard to any single country. Health is one, crime is another, risk of terrorism another, natural disaster, et cetera. We look at information that we draw from a variety of sources. The UN provides some information on health issues. We talk to the Bureau of Diplomatic Security with regard to the crime and terrorism risks. We pull information from the intelligence community. In other words, from a variety of different sources. We talk to our friends, the 5 like-minded countries, UK, Australia, et cetera. We gather all this information. We use a fact-based matrix to try to decide whether we're going to rank a country 1, 2, 3, or 4.
Great.
I hope that answers your
Thank
question,
you.
sir.
Dr. Redfield.
The purpose of the CDC levels is really a different purpose. It's really for public health purposes only. And we actually have 3 levels. It makes it confusing. We have the first, which is just an alert to let the American public know that there is an ongoing infectious disease issue. And so right now for the alert, Singapore, Taiwan, Thailand, and Vietnam. Once we see that there is significant human-to-human transmission, so it's not just, hey, there's something going on there, we go to what we call a level 1, and right now that's Hong Kong. When there's actually multiple clusters of human-to-human transmission, then we go to a level 2, and that really tells people, particularly if you're older or if you have any comorbidities, you really ought to reconsider travel. And that right now for us is Iran, Italy, and Japan. Now this changes every day, as you said. And then level 3, we're telling people, this is when we have broad community-based transmission. We're telling the American public that we recommend they don't travel. So those are our levels. And we're reevaluating them every day based on the data that we see of what's happening in the country at the time, really around human-to-human transmission, how isolated it is, how broad it is. And right now, obviously in Korea, we have very broad transmission throughout the country. It's moved to a level 3. China, very broad transmission out the country. But you should anticipate that these are going to continue to change. They can go up or down. I wouldn't be surprised if we don't have changes even in the next 24, 48 hours based on what's happening in these countries.
Thank you, Dr. Redfield. And Mr. Fritz, I know you're on a tight timeline, so we appreciate your being here if you have to leave the panel. Thank you. If I can, ask Dr. Walters a question, because again, I appreciate your coming down here and making yourself available to us. In thinking through the evacuation of some of the Americans on the Diamond Princess and so forth, there were reports that positive testing patients, and again, it may be that those results weren't communicated, or I'd be curious, but some of the positive testing patients were commingled with negative testing patients, and just curious how that might have happened, and then how we avoid that happening in the future. Thank you.
Mr. Chairman, thank you for the question. The timeline matters. So the decision to evacuate American citizens from the Diamond Princess was not based on, there's an outbreak of COVID-19 on the ship. The decision was based on there was evidence of ongoing person-to-person transmission. This was a problem that was not getting better, was getting worse. And despite the best efforts of the government of Japan. Once the decision was made that it was safer to move these American citizens, many of whom were in an age range that puts them at the greatest risk, we followed protocol. This was I think the 6th flight that we had done in like 2 weeks. Each of those individuals, each of the 329 individuals that we took off that ship were evaluated by a medical officer from either the State Department or Health and Human Services, ASPR, within that 24-hour period. The embassy in Tokyo had reached out to the Ministry of Health, Welfare, and Labor and asked that all lab results be reported by 4:30 that afternoon. The evaluations were done, the evacuees then were handed from the government of Japan over to the care of the United States government. They were disembarked from the ship, they were loaded onto buses, and this was to be one single movement of 15 buses from the ship to the airport. It was only once those evacuees were 329 people on 15 buses, and in the minutes after midnight on the docks at Yokohama, that an official from the government of Japan approached the embassy personnel with a list. And on that list were 16 names. And of the 16 names, 14 people were manifested, and some were on 15 different buses. And the buses were already in movement. In the movement from the docks at Yokohama to the airport, there was some discussion, hey, we've got this problem, we're working through it. And that's only a 40 or 45-minute movement. Once they arrived at the airport, the 14 were identified in a way that was efficient but protected their privacy. And it's important to remember, none of these individuals had symptoms. They were not coughing, sneezing, they didn't have fevers. That had all been confirmed. They were removed from the bus. They were taken to the only place. Now imagine, morning is breaking at that airport. It's raining. These are 60 to 80-year-old American citizens that are helped off the buses and put into an isolation area aboard the aircraft. The way the aircraft is set up, the airflow moves from the nose to the tail. So the sort of most at-risk area is near the tail of the aircraft. We had already partitioned off, as we had in previous flights, an area to protect other passengers from any contagion that might be with those folks. And they were placed there, and then there was a robust interagency discussion. Much has been made about the discussion, but at the end of the day, we reached consensus. And there was consensus between the department, our partners that we rely on from Health and Human Services, State Department, and others, that yes, these are evacuees. Yes, they've been placed into the care of the U.S. government. Yes, they are contained and they pose no further threat. And with that, we brought them back to the finest quarantine facility in the world to receive the best care available.
Great. Thank you for that explanation. I know the ranking member had additional questions.
Yeah, and that's for State Department, because we heard over in China how I think it was 1,600 health workers came down and they were sick. We had talked to our ambassador from Cambodia. We had a discussion with him today, and he was saying what a stellar response our State Department did of working 24/7 at 6 different locations, moving people out. What kind of protections do we have for our State Department personnel? Because I know when we go on Codels, you guys work your tails off, and we appreciate it. And we want to make sure you have the coverage and the health care that you need. You feel adequate?
Yes, sir. Thank you for the comments and the question. Here's what I would say. This is an international emergency with significant domestic risk. But in 220 locations around the world, we have a workforce of 75,000 people, some of whom are in countries that have active cases. Others are in countries that may tomorrow find themselves with active cases. We learned our lessons in 2004. We learned our lessons again in 14, 15. And we're thankful to Congress for the support we've had in the preparedness side of this. There is PPE at every embassy. Our healthcare workers, a workforce of almost 700 in all these locations, are well educated. They are well prepared. We continue to look at our resource requirements, and we continue to look at our authorities, not just to take care of American citizens, to the chief of mission personnel, but really in that global picture to protect Americans.
And we feel confident that if an embassy were to come down and the workers get exposed, that we can get the supplies needed in there. If it's in an area that is more remote where we don't normally have good health care, maybe that we can get it in there in sufficient numbers. We feel like we're protected there, right?
So there's 2 parts to that answer. The first part is the same aviation contract that made these evacuations possible is the same aviation contract that makes delivery of critical supplies possible. The second part to that is actually a greater risk. And the greater risk here is when you look at the way we do medical evacuations of chief of mission personnel around the world, they don't typically come back to the United States. They go to medevac centers with established relationships in South Africa or the UK. Those countries are now making it more and more difficult in a way that you can understand to bring non-UK citizens or non-South African citizens in if there's any risk that they have COVID-19. So we continue to work with our international partners to keep those diplomatic platforms open so that Dr. Redfield's teams have a place to work and the resources and relationships to do it, but still be able to medevac our chief of mission people home when the time comes.
Okay, thank you. Dr. Redfield, again, there's this cloud of lack of transparency that we keep getting from China. What signals can we see from China to see what the real extent of damage is behind the containment? The National People's Congress meeting has recently been canceled. I mean, that's a pretty strong signal to show that that threat is they're really that concerned about it, as they should be. But then with the people over there not getting, an open press where they can get reliable information, Do we feel like they're being forthright with you? I mean, you're working with them on a more of a scientific platform. Do you feel comfortable with the information you're getting?
From my colleagues, the scientific interaction we're having with our CDC colleagues and from the China CDC, I'm very comfortable with it. What we have, as I said, I have my own director of the American CDC in China. They're regularly interacting. So at the scientific level, we're having collaboration. I really can't really comment beyond that. I will say it's worth noting that they've probably introduced some of the most aggressive containment mitigation strategies that we've ever seen on the planet, I think, in the history of the world. You know, but and I would like to say, just though people are feeling better that there's a reduced number of cases in China. Just last night,
if that's accurately reported.
If accurately put, but even then, it was 434 people, and over somewhere between 25 and 30 deaths last night. So they still have a major problem despite everything they've done in mitigation.
I want to throw one thing out, and I don't really expect an answer on this. Being a veterinarian, we've seen the porcine viral diarrhea syndrome broke out several years ago. Within a year, it was in America, lost about 300,000 sows in America. African swine fever broke out, I think it was May of 2018. I can't remember the exact date. We've not seen that here, but we do know this. It is a very hardy virus that can be transmitted in different fomites. It can resist freezing, it can resist heat, and it can make the shipping from China to the United States in containers in different materials, whether it's feed, packaging. And so this is something we need to be alert through APHIS, through USDA, through CDC, that we're monitoring these things better than we ever have before, because that's a port of entry that we might not even be looking about. We're looking at people, but we also need to look at containers and fomites coming in that way.
Yeah, the only comment I would make for this virus, just so you know, we are aggressively evaluating how long this virus can survive and be infectious. And where on copper and steel, it's pretty typical. It's really pretty much about 2 hours. But I will say that on other surfaces, cardboard or plastic, it's longer. And so we are looking at this because we don't know the role of fomite transmission. Now, I don't think it's going to impact cargo, okay, unlike maybe some of the other viruses that you've talked about. But I do think that it may have contributed to the huge outbreak we saw on that Diamond Princess. It may not have all been aerosolized. It could have been fomite. So we are aggressively evaluating that to understand how well this virus survives in different conditions.
We'd appreciate you keeping us informed on that. Thank you.
I understand Ms. Bamberger has an additional question.
Yes, thank you, Mr. Chairman. Since we have been in this hearing, there's a breaking story with the Washington Post, and I don't expect that you all have seen it yet, but there's a whistleblower report that a senior HHS official who oversees workers at the Administration for Children and Families has now filed a whistleblower report that HHS employees were sent to an airplane hangar to meet evacuated Americans at the March Air Force Base in Riverside, and that they were not given any PPE or protective equipment while they were interacting directly with those who were potentially impacted. I raise this recognizing that we're dealing with different agencies here present today, but I think this speaks to a general concern. It's a little bit of a follow-up to Congressman Bera's question related to whether or not State Department officers have what they need to stay safe. And I'll pose that question, but then also wanted to make sure to make the point that this is deeply concerning, because as we're dealing with a significant outbreak, something that is personally causing great fear in our communities among individuals, we need to ensure that our constituents have faith that the administration and that the U.S. government's doing everything possible. And there's already some concerns about whether or not that's the case and how people can keep themselves safe. And so finding out that the U.S. government might have put its own personnel in harm's way is deeply concerning to me. So if you could comment both whether or not your agencies are ensuring that their personnel are safe, and then comment on, what we can do in light of this when we're back in our districts and people are saying, how can we trust the government to keep us safe if this is happening to its own people? I'd love your comments on that.
Thank you for the question and the concern. I can speak, having been on those missions, and certainly the first trip out of Wuhan, the second, the third, the Diamond Princess, and based on a relationship that I've had with HHS, ASPR, and CDC dating back to 2014, every precaution has been taken.
So was it your experience that you did not witness any individuals who were not wearing PPE?
No, I can say unequivocally that everyone involved with those evacuations was appropriately equipped and trained.
Okay, well, and I don't seek to be argumentative with you, sir. I'm reading what's a breaking news in the Washington Post, but that is good to hear. And then specifically with State Department officials and the availability of protective gear and the attention to detail there.
We take every precaution. We have the equipment and the training that we need to do this safely.
Thank you. And would you care to comment as well, Mr. Brownlee?
Yes, please. My consular colleagues in China, Japan, and elsewhere have been working on an ongoing basis with people. So, for example, in Japan, there are still 100+ U.S. citizens from the Diamond Princess in the country. A number of those are hospitalized. We are regularly engaging with those people, but we're doing so in a safe fashion, taking professional advice. So whereas initially some of the visits were taking place in person, that became cumbersome because they were having to suit up. Now these visits are taking place on a telephonic basis. I have here a photograph, I gave the chairman a copy of it, that shows my colleagues standing on the quayside as they were processing people coming off the Diamond Princess. They were properly taken care of.
I can see the photo from here that they are.
I'll leave you a copy.
That they are equipped. And then the general concern about, again, this is just report that is breaking news. The veracity of it will be determined later. But it is in the news and people are reading and it's adding to the story. Are there other comments that you all would like to make related to ensuring that our constituents, the people we represent, have faith that we're handling this, that all involved agencies are handling this virus and concerns in the way that it should be handled? And just in light of what might otherwise be some concerning news.
What I would say is that the psychology in dealing with highly infectious disease is often worse than the pathology. That we have the best medical care in the world, and whether it's Ebola or coronavirus, the American healthcare system is ready to receive and ready to take care of our healthcare workers and our public. From the State Department's perspective, we have a workforce that is at the front line. We are happy to be there to facilitate the relationships that are going to be critical for containing this overseas, whether it's the delivery of foreign assistance or the exchange of technical information. What I tell my family is that you live in the best country in the world, and that that people who know how to do this are in positions where they can advise state, local, and international healthcare workers.
Thank you. I thank you for the indulgence of the second question, Mr. Chairman, and to the witnesses. Thank you so much for all of the work I know that you are putting in on this. Thank you for your continued service to our country and to keep us all safe and healthy. I truly appreciate it. I yield back.
Thank you. Let me recognize the gentleman from California, Mr. Sherman.
Doctor, what's your best estimate as to the mortality rate of this disease among those who are healthy and under age 65?
Again, I think the most important thing in that scenario, under 65 and healthy, is whether your health system's functional or not. So as we've seen with the Wuhan health system, which is...
healthy health system, healthy human under age 65.
Yeah, well...
My constituents.
Yeah, I think, again, we don't have the data, but we suspect if you look at the mortality rate of this disease outside of China, we're probably looking right now at somewhere around 0.5%, right? But again, we'll have to see more data to really be clear on that.
And seasonal flu has a mortality rate of
About 0.1 per 1,000.
0.1 per thousand or 0.1%?
0.1%, I'm sorry, yeah, 0.1%.
The Chinese are telling us that there's a decline. Should we believe them? Doctor?
I think that there probably is a decline. That I do think some of the mitigation strategies are starting to have impact, particularly out of Hubei. Most of the cases now are in the Hubei area.
I want to ask you about masks. It's funny, I went on to Amazon, buy 50 masks is $50, and it's, they're not very heavy. It's less than a pound. And then Amazon wants to charge an additional $400 for shipping and handling. Needless to say, we'll be in touch with Amazon on this, but I don't think that Amazon has ever charged $400 to ship a box, and not on a rush basis, actually, a delay for 2 weeks from now, one less than a pound, $400 shipping and handling seemed an extraordinary charge. But given Mr. Bezos' need for food and the necessities of life, I can understand. We see pictures from all over the world, people wearing these masks. Who should wear the masks in the United States?
Yeah, as I mentioned earlier, the masks, the N95 masks, really need to be reserved for healthcare providers that are taking care of these patients in the hospital, as well as confirmed individuals that are in home isolation to minimize the spread while they're in home isolation. We would not recommend the American public go out and get these masks.
Does the mask protect the person wearing it or protect others from the person wearing it?
Well, there's really the issue here is to protect the individual who is being exposed to someone who has the pathogen. And we believe that that's where the mask should be. A lot of the people you see wearing these masks, they're really not going to have a functional impact whatsoever in terms of transmission. These surgical masks that you see everybody wearing even when I was traveling today here in the city, I saw people again, and even in our own city, wearing masks. Some of them do it that have a cold or an illness that they think it might minimize them. I would tell those people to stay home. That would be more effective than trying to feel that you have to go to work and wear a mask. So I think the CDC has on its website really good guidance on the appropriate use of masks, and I encourage people to go look at it.
Now, it looks like the Chinese have had a decline. They've dealt with extraordinary lockdowns of entire areas. Should we be locking down any neighborhood where we find that someone, what level of lockdowns do we need, if any?
Yeah, the backbone of our response right now, and really the most important part of our multi-layered response, even though sometimes people don't recognize it because it's not like travel restrictions or screening at airports. The backbone is the American medical community and public health community. As I mentioned, of our 15 cases that we diagnosed in this country, 14 of them were diagnosed by our medical public health community. So I'm going to maintain confidence on early diagnosis, isolation, and contact tracing as our major mechanism to confront this.
To test for this, is it sufficient to just take people's temperature as they were doing, or is it contagious before it's symptomatic, and do we need to give a lot of people blood tests?
Yeah, so the issue on how infectious this virus is at different states of symptomatology is still unknown, but we do know that you can transmit this virus before symptoms. Does that contribute meaningfully? We don't know, and I think that's what we're trying to learn. Clearly, we and CDC is working on another other test, which the chairman would understand. We're trying to develop serological tests so that we can understand the extent. Like in China right now, what they're doing is they're measuring the active virus, and that's what we're doing. But that doesn't really tell us what the denominator is of who's really been infected. You need a serological test to do that. We're currently working.
So I know the chairman understands what you're saying. You're saying we want to test to see which people have been exposed, have the antibodies, and may have been asymptomatic throughout the whole process?
Yes,
or
sir.
at least didn't know they had the disease?
Yes.
Gotcha. See, now you're not the
There you
only
go.
member up here who understands it. I yield back.
Well, thank you. Once again, I just want to recognize and say I appreciate the service to our country, and obviously this is a very fluid situation. I did just want to make reference to the breaking story that Ms. Spanberger identified. I'm fully confident that we do everything we can to protect our personnel and our workers as we were evacuating folks from China, putting them on airplanes, bringing our citizens back home. It does sound like there was someone who did see some personnel that did not have protective gear and were released. I hate to use the term whistleblower because it's gotten politicized, but it is important that if there are folks that are raising issues, and I do feel that it's very important for this body to say publicly, we want to encourage folks who see things for the sake of bettering ourselves, those whistleblowers or those individuals that are raising issues. We are fully committed to protecting them, and we fully want folks that are seeing things to feel comfortable and protected from coming up. Not commenting on whether this story is accurate or inaccurate, but I am commenting on the fact that it is important for folks that see things to identify them and not fear retribution for coming forward. That is our law. That is the way this process works. Dr. Redfield, I appreciate you're coming up to the Hill and keeping us informed. Again, in conversation with my colleagues at UC Davis, we look forward to working very closely with the CDC. And, as one doctor to another, as we work through the regulatory process to speed up our testing capabilities and the availability of diagnostic tests throughout this country, we look forward to working with, well, you're not the one holding it up necessarily, but we do look forward to speeding up that regulatory process to make sure we get these tests out and are able to do it. And again, I appreciate updating the folks that we are testing. I do think that is going to be helpful, and trusting our doctors that are on the front line if they do suspect coronavirus, being able to get that test in. Did you have?
I just want to make one comment for the record, that we have been working very closely with the FDA. They have been very supportive. I just want to make sure, but they're operating within the regulatory framework that we have. And I think the point that I wanted to make is that the loss of laboratory development tests to be used when we're developing new tests and responding to new emergencies, I think is something that should be relooked at.
I appreciate that. And again, thank you, and thank all three of you, as well as your colleagues at HHS, USAID, Homeland Security, for regularly coming up to the Hill to brief members of Congress. And again, this is fluid, so let's maintain close contact and dialogue. And with that, this hearing is adjourned.
Yeah.